So anyway, it is October 5th, 2021. This is the BE Collection. I'm Diane Barrett, and I'm introducing my friends and professional colleagues, Margaret Elfring, MD, Jennifer Black, MD, Lindsay Ralphs, RN, and myself, RN. And we're presenting pain management and hospice. I think that fear is the enemy of all of that. So hopefully today with some information, we can lighten people's fear, including our own, when it comes to those problems. So I thought we'd start first with discussing hospice, and we'll all ask questions intermittently. So Lindsay, did you wish to start?
Sure, I'll start. I want to give you an image of why hospice actually is important. And the image is because my family did not have hospice. My mother and sister died within a year of each other, and hospice came to America the next year. And so they died at home, and none of us knew what to do. We didn't know how to take care of them. We didn't know what it was supposed to be like. The one blessing was that my dad could give injections. And so he was able to give my sister injections of morphine for her really unremitting pain. So later on, when the AIDS crisis came on, there was a facility hospice called Chris Brownlee Hospice, and I started to work there. The thing that was different about a facility hospice than home hospice is that because everybody there all had the same disease, even though different manifestations, and all of them knew they were going to die, dying was normal. That was our state of normalcy. If somebody healthy came in, they just didn't fit. Then after I did that, I did some other work, and then I went into home hospice.
Talk a little bit more about the Brownlee Hospice. I think that would interest a lot of our listeners.
Well, Brownlee is not like any hospice you would find today, because it's a facility, or it was a facility, and almost all hospice today is home hospice. All I can say is it was a gorgeous experiment in death and dying. Even though it was really hard and really sad, and a huge amount of young men died there, we were able to be a part of living death, the people who worked there as well as the people who were patients there. We were their support systems, we were their caregivers, we were the people a lot of times who were the only people there who stayed with them, us and the volunteer team. So
who established that hospice?
A guy named, I cannot believe I just went blank on his name.
Chris Brownlee? Did he start it?
No.
That would make sense.
Yeah, but it doesn't. It started in memory of him, and it started by the guy who's the head of AIDS Healthcare Foundation.
I see.
Who is a brilliant guy, but he named it after Chris Brownlee. I think I read that Chris Brownlee may have seen it, but I don't know. But we had 23 beds. Every bed was individual. The people there ranged from really wealthy gay men to street gangs who were, who had been using drugs and got AIDS from drugs. So
did you have to be gay to be there, or did you have to?
No. We had like the kids. We had a couple of kids who came in who were like in gangs and had gotten AIDS from injections of medications, and it was kind of fine, except they got a little scary because their gangs came, but we all became adjusted to it. But it was the interesting thing. It was like almost a social study. For example, the building was on two levels. On the top level was where the healthier people were. They were the people who could get up, walk around. They could go on pass when they wanted to. The people downstairs were no longer able to walk, and that was a definitive thing. So they were too sick to walk. And the people on the top floor didn't socialize with the people on the bottom floor. They really kept their distance and were very social with themselves and each other. But I think knowing that where they were going next was just intimidating to them. And there was one kid there who was a tall, skinny guy who was straight actually. And he had AIDS, and it got worse and worse and worse and worse. And he couldn't walk. And we're like, you've got to go downstairs, Tom. You know, it's time for you to go downstairs. And he was like, no, I don't need to. So one day the fire marshals were there, and we're like, the fire marshal's here. You've got to be able to get up. He got up and walked by the fire marshal, holding onto the railing, but as dandy as could be. And the minute the fire marshal left, he just collapsed. We picked him up and back to bed. Yeah. Wow. He never adjusted to the fact he was going to die, which is interesting. And we found him actually flung kind of out of his bed. And the myth that grew up about that was sort of that he was really trying to escape death. He knew it was there for him, but he wanted to escape it. You know, home hospice, though, is significantly different because death is not the norm there. It's much easier to deal with death when it's the normalcy. It's not as easy to deal with death when it's not the norm. And if I compare my family and Chris Brownlee, it's like, what a miracle it would have been to have Chris Brownlee with, Brownlee Hospice with my family, to, hold our hand to show us it's normal and on and on. But that's what home hospice at its best does. Home hospice, I worked in home hospice for about 15 years. 10 of them were as a manager, a director. And what's important to bring out about home hospice is that, one of the things that the fears, and Jennifer will talk about this, is that your care, you're going to be isolated. Your care will be taken away. You're not going to get good care anymore. You're just being thrown to the wolves. You're being taken away from your doctor. And people are terrified by that. They're terrified that they will have no agency. It's important.
I understand that, right? I can understand that.
Sure, absolutely. The important thing about knowing, or about being in hospice, knowing about hospice, is hospice is really there to help you, not to make your life easier, basically. That was one of the big foundational points, was that we wanted people to be comfortable, and we wanted their life to be as easy as possible. We wanted.
How long did home hospice, when did that start?
In America, I think it came in 1972. And its model was the European model, which actually Canada still has, which is that hospice is a place, and you have to go to it if you want to be in hospice. Here, it just didn't work. It got very popular in the South and still is, but it didn't catch on. And in my experience, it didn't catch on well because people didn't want their loved ones necessarily to go far away from them or to go someplace else. But so what hospice gives is a complete program where, the person and their family get a team working with them. They have nurses, they have hospital or HHAs, home health aides, they have chaplain, they have a social worker, and then on top of it, they have a doctor. They have pharmacists available on call. So it's a very close-knit team who make the care as complete as they can. And Jennifer will tell you, in hospice, the biggest thing is not pain. It's a huge thing, but other symptoms are just as dire. There are people who can't stop throwing up or stop nausea, and that is a horrible symptom. There are people who are just horribly dizzy. There are people who have horrible anxiety. And the hospice team's job is to help manage those symptoms without the patient having to go to the hospital, to the doctor's office, to see another doctor and another doctor and another doctor. We're also there to help the family understand what's going on and to make them realize that hospice is sad and it's terrible, but it's also a thing where you can give comfort, you can feel wholeness, you can feel completion. And so the fact that it's such a scary thing is sort of horrifying to hospice people. So as Jen well knows, and we'll talk about, and I will turn it over, is that people think the minute you go in hospice, you're going to die. So Jen can talk about that a lot.
To interject the story about my mother.
Oh, yeah.
I think she's a dedicated part of this to my mother. She was a very determined, strong woman. When she said, "This is Mrs. Barrett," to whomever, she was listened to. She had metastatic cancer. Her internist referred her to an oncologist. She knew that was not a good idea. And she and my father went, and unfortunately, it was a brutal interview where he mentioned hospice, and they were prepared to hear that. Then her internist found a more gentle oncologist and talked about it. And he was, my sister and I were there. He was a magnificent person. He talked to her about her life, or what was important. He took 3 hours to spend with her. It was a real gift. However, then the time came for her to go on hospice when my father couldn't handle helping her anymore at home. She probably took 1 Valium and died. And the hospice nurse was admitting her. She was doing the paperwork in the kitchen, and I knew my mother had died. I heard her stop breathing. Mm. She said, "She can't, I haven't finished my paperwork." And my mother was so frightened, and so determined to die. She finally relaxed after all this input from this person and that person. And the Valium probably just helped her die. She did. Mm-hmm. So that's the fear about hospice is huge. And
it's true. And one reason I think that people have the impression, and by the way, I'm a hospice physician. I have been for the last at least 15 years. I do hospice, and I've done inpatient and clinic and home-based palliative care as well. Hospice is my favorite service to work in. But I think one of the reasons that people think people die the minute they get on hospice is because physicians for many years didn't want to refer to hospice, because we're trained to save lives and prolong lives. And we've never been trained, at least during our medical school and residency, there was not much about end of life care. And our main goal was nobody dies on my watch. No one's going to die during my shift. And so hospice was seen even by physicians as giving up. And it's still true even today that about 1/3 of patients die within 7 days of coming onto hospice. That may create the impression that hospice is causing that, but it's really just because of late referrals. So ideally, patients can benefit from being on for at least a few months. So we have a chance to get to know the patients, the whole team can come on and get to know them, and we can actually do a lot to support the patient and family.
Do you think that the word hospice sends a message, a clear message?
I think it does scare people. And I think that, we've tried to just call it palliative care. We've tried to call it supportive care, but no matter what you do, once people figure out what it is, it still scares them, because I just think we live in a death-defying, death-denying culture. So I think that's part of the problem. A lot of other countries don't fear death or avoid the conversation about it as much as we do.
I heard people talking about, they even asked me, why are doctors so arrogant? And I said, some of that goes with the territory, because people are saying, how much longer? And there's asking the doctor to establish life and death. And the doctor does try to calm that down and give the information. But anyone that's given the mission of saying, well, I don't really know, we'll see how it goes, has to be a little arrogant in my book. Okay, I'm gonna.
Right. Because we do know by the time we get closer to the end of life, we do have basic ranges that we can tell patients as far as their disease, but we have to make it clear that every patient is different. Every disease is different in each patient, and nothing holds true for everyone. And some people want to know details about what's happening with their illness and how long they might live, and other people don't want to know. So it's important to have those conversations. Yeah. Do you like your eggs sunny side up or easy over? How do you like to have this conversation?
Yeah, it was interesting.
I'm an orthopedic surgeon. And one of the reasons I liked orthopedics is because the problem of death wasn't there. Mm-hmm. It was a matter
in surgery.
Well, in the whole division of orthopedics,
right?
Death is not an issue. You don't die from an orthopedic surgery or an orthopedic injury by and large. However, I think that the patient has that fear that they could. Oh, absolutely. In the family. And I used to do something, if someone broke their hip, typically as an orthopedist, you see them the next morning. You don't see them in the
Yeah. You know what's really funny, Marge, is that my first death when I was a resident was a patient who had just had an orthopedic surgery.
Really?
They had just had their leg amputated. It was an 100-year-old patient,
Wow.
a Hispanic man in my county hospital, and he had his leg amputated. And he woke up the next morning and he looked down and he realized his leg was gone, and he had not wanted that to happen, and he died.
Well,
So, yeah.
I tried to give patients the option of telling me not to do something. And one
Mm-hmm.
went to the hospital with a gentleman who had fractured his hip. He was Asian, Japanese, I think. And I was talking to him and he said, I don't have the energy to do that. As simple as that. I don't have the energy. And I believed him. And he died 2 days later in traction, but he didn't die in surgery because he told me, don't do that to me.
And you listened, which is so important.
Well, I mean, you should live. That's my job.
It is, but it isn't always what happens, because I've heard a lot of physicians say, you don't want to just, if you don't do this, you're going to die. And
Well, no, he was
a variety of other such,
telling
and he did die, but
on his way to.
it's not always presented as a choice. And so it's good that you presented it as a choice.
Well, one of the things I've learned is that some cultures view surgery or changes of the body like surgery as a horrendous negative.
That was what was true of that gentleman that I told you about. He had not realized that he was having his leg amputated. His family had been told that he would die of sepsis if he didn't, and they gave consent for him, but he didn't give consent for this. So you're absolutely right.
Yeah, it's really from culture to culture. As a physician, I found I really had to listen carefully to see what that culture would present in the complex of everything, because it wasn't what I was used to.
Yeah.
Typically,
And cultural issues come into play with regards to myths and misconceptions about what hospice is too.
sure.
I had a nurse friend who was in the hospital. She came into the hospital to meet with a large family, Hispanic family, who had a grandmother, I believe, who was not doing well. And I think there were maybe 12 people in the room. So she had a conversation with all of them about hospice, about going home, getting the bed, all sorts of things that hospice would provide. And at the end of the visit, she said, do you have any questions? And they looked at her, and one of them said, when are you going to, she says, when am I going to what? And someone else said, well, when are you going to do it? And she realized that they thought she was going to euthanize their mother in the hospital. So that's just one of the many, many misconceptions that people have about hospice, that hospice hastens death, that it's euthanasia, that you lose your insurance, that if you take morphine, it means you're going to die, or a lot more.
So if somebody has a significant other in the hospital as a patient and hospice is recommended, how do they who makes the contact for them?
In the hospital, it's usually the discharge planner, or sometimes we call them care coordinators. So there are nurses who are in the hospital, and if the patient's a Medicare patient, by law in most states, I know this is true in California and in Oregon, they have to be given a choice of any hospice that's available to them that's Medicare certified. So they give them a choice, and then they actually will call the hospice for them, and the hospice will come in and see the patient in the hospital and give them information.
Well, I suspect that the reason hospice is associated with the death of the patient is they get home, they get relaxed and get some medication to relax a little bit, and they let go. That's my mother's belly. Yeah. Her mother.
That's true. That's true. And I think that's one reason why people tend to be worried that morphine or lorazepam or whatever we give to patients in low doses kills the patient. And it's more often than not, in my many years of experience in doing this, people are just so happy to be home and they're able to let go. Their family has told them it's okay. They've changed their goals over to comfort measures and they're good with that. They're feeling peaceful, and then it's time. But it's not the medication that does that.
The relaxation of the person. I mean, her mother controlled the world. She tried to, I mean, really. And when she let go of that control, she was gone.
Yeah. Lindsay, what were you going to say?
I was going to say, I noticed a lot of patients that if they were anxious in any way, they had a really difficult time dying, including people who wanted to die too much. I had a young man who all he wanted to do was die, and he was really angry. He wasn't dying, and he wanted to die faster, and that's all he talked about. He had all this energy around him. And finally, I kind of said, you have a lot of control, but you need to let go of this because you're putting too much life into wanting to die. And he actually got a thing that we got him settled down, we got him less anxious. And the rest of his life, which was actually about a month, was just the way he wanted it. But he was so frantic to die that nothing was going on. It's the same thing, people who are too frantic not to die. The body kind of responds to either one of those in the same way. It just holds itself.
Mm-hmm.
The minute you get morphine or an Ativan or something that relaxes that, a person can go, oh, now I can relax, and that lets them let go. And so as you said, there's a lot of that. People will die when they get this medication because they're no longer hurting so much, or they're no longer so anxious, or they're no longer. On the other hand, I have patients who are absolutely able to control their death, which was fascinating. I had a young woman who was exactly my age at the time, who had a massive tumor, probably ovarian, in her leg, and just, she lived alone with caregivers. I was her prime nurse. She didn't want to see anybody else. And the caregivers called me and said, we think she's dying. So I go dashing over there, and I think she's dying. I mean, she is just laid out. She's agonal breathing. She looks like she's dying. So I go out with the caregivers to kind of talk about what to expect. And one of the caregivers goes in and she says, she seems to be awake. So I go back in and I said, well, how you doing? And she said, well, I almost died there, but I wasn't going to. I said, we noticed that, and welcome back. She did it again. And she came back again and she said, I'm not going to die because you people want me to. I know you're all just sitting here wanting to die, and I am not going to, damn it. And I said, let me tell you something. There is nothing on earth really we can do to make you die. You get to choose your death. You get to choose when you're comfortable dying. It's not my choice. It's not your caregiver's choice. We're here to support whatever you want, but even if we wanted to, we couldn't make you die. And she was like, are you lying to me? And I said, I have not lied to you in the last 5 months. I am not lying now. She went, oh, so I can do this on my own. So it's my decision. Sure is. 3 months later, bam, yeah. She died within 3 or 4 minutes. I had walked out again and the caregiver came, she's dead. And I went back in and she actually was. She had died. But she needed that control. And I was amazed. I mean, I've never seen anything quite that amazing and conscious. But yeah, so people have, it's not like we can come in and magically make people die also, because people have a lot of, they have some choice in their death and in their life. And, part of our job is to go in and help them with these choices in their death and their life, but not to step on them, not to abandon them into a world where they're like prisoners. I think it is the most freeing of any of the medical specialties and nursing specialties. I also think that the worst thing a person can do is go to the hospital if they're dying, because even with hospice, it's okay. But I've known people who have gone off hospice because they want to die in the hospital, and it's just miserable. I won't go there. It's horrible.
It is. A lot of people think that the hospital is the right place to die, but it is not.
It's because
It is not.
they think of
It's interesting how, Lindsay, you're mentioning that people have some control over the death process, and that's, for my years of doing this, absolutely true. They will wait for someone to get there before they die. They'll wait for someone to leave before they die. And I remember my wife, Susan, was a hospice nurse for years, and she had one patient who said, I'm going to die on this day. I want you to make sure my wife is not in the room. And there was more to the story. He even sent flowers to her that she got on the day he died, or after he died. But he did die on that day. She did accidentally let the wife come in the room, and she could feel his heart rate getting faster. And she said, "Oh, I remember that he wants you to be outside the room when he dies." So people have some control.
Yeah.
My mother called my sister, who she took care of for many years. That was her final phone call, and said she wanted her to come because my sister lived in Massachusetts. That was the last phone call. I remember being a nurse's aide. I was 15 and working on a medical floor. People went to the hospital to die, just like what you said. And it was 26 died. We would get the gurney, put the toe tag on, we'd get the family Jello and coffee and iced tea or whatever. And we could have 6 people die in a night.
Yeah.
And, off we go to the morgue and we'd start again. So when I heard about Elizabeth Kubler-Ross in the 70s, I went to hear her in Chicago talking about hospice. I thought, wow, this is really something. This is humane. Even at 15, I knew something was wrong with that process. And the family had no time with the person had no time, and they just became a trip to the morgue. Jello and
yeah. And also, when people get older and sicker, they reach a point where they're not going to get better. The hospital's not going to do anything to make them better. But unless someone talks to you about this, they talk about goals of care, talk to you about options, people just go in and out. We call it the revolving door. They go into the hospital, they get a little bit better, they get sent home, they get worse again because they need caregiving. They end up back in the hospital again. And it is that revolving door. And it's really important that folks have someone to talk about when is enough enough. When do we want to change? And that they know that they have those choices, that they know that they have programs that can help them focus on comfort care rather than continually going into the hospital and putting Band-Aids over the volcano.
I'll never forget a lady who I first ran into. She'd fallen, broken her hip, fixed the hip. She did well. Her family, she was antagonistic person, and her family didn't like her. Nobody in the family seemed to like her, so nobody wanted her home with them. So she went to a nursing home, where within about a month she got into a horrendous fight with someone else in the nursing home and came back into the hospital, unfortunately to me. And she said, I don't want to go to a nursing home. And I said, fine, what else can we do? There was not another option.
Yeah.
She just said, I am not going, that's it. She closed her eyes, closed her mouth, and died 2 days later.
Yeah.
It was just, I can't make her eat.
That's enough. That's it. Yeah.
IV in her,
Yeah.
She would. My book was that's what she was determined to do. She did it, and she did it.
Yeah. One of the things I
Really have a lot of other options, I would say.
Can a person who they know they're dying, but they don't have a physician to request hospice care or any home health care, can they contact hospice themselves?
Yes, they absolutely can. They can call hospice to ask questions. They can have hospice come out for an informational meeting. But in order to be admitted to hospice, they have to be evaluated. And so they have to have a doctor's order for that. And then a nurse goes to the home, and the hospice physician and the nurse together decide whether they meet hospice eligibility criteria, which Medicare has set. I always tell patients if they have a physician who says, "Oh no, you're not ready for hospice," or they're hesitating because they think that they're uncomfortable with it, ask another doctor, because some are just not comfortable yet or not as comfortable with prognosis. It's been shown that the better you know a patient, the worse you are at prognosticating for them.
Yeah.
That's like Marge's sister was dying. She had metastatic cancer and she needed pain medication. So she called Marge.
Mm-hmm.
She has Tylenol or something. And then Marge tried to help by calling her physician, and you can tell the rest of the story. Right.
Yeah, my sister lived in Oregon, where you can do suicide if you wish, under certain criteria. And at any rate, so I called this physician because my sister was just in agony. And I said, how about something a little bit more? Let's go in. Have you thought about using morphine? The guy went ballistic. He thought I was suggesting that he give her medication to commit suicide. Now, my sister was an ultimate Catholic. I mean, at her funeral, there were like 5 priests coming to pray for her. I mean, you wouldn't get one in my door. But it was that whole thing of, I mean, it took me a long time on the phone to convince the man. It wasn't suicide I was talking about. It was reasonable life until she died.
Mm-hmm.
Right, exactly. And medical aid in dying, that's what we call it now. We don't call it suicide anymore, really just medical aid in dying, because people who are eligible for that do have a terminal illness. They generally have to have a prognosis of 6 months or less, and they're just able to obtain a prescription from a physician to die when they're ready during that time.
It's a really very reasonable law.
Mm-hmm.
I agree. It's been here in Oregon since, I think, 97, maybe even before that. And then it's been the law in California for the last several years. And then it's also available in a number of other states. I think maybe 16 other states. We have a resource that will attach to video mentioning how many.
Wow.
You know, it's.
I think Oregon was one of the first, as I remember.
Yeah, Oregon was the first. Lindsay, what were you going to say?
This makes me think about the myth that people are put on hospice because we want them to die. Somebody wants them to die. The family wants them to die, and they're going to get this massive morphine. They can kill themselves with it, and that is such a wrong perception, and it's such a common perception. That our job is to make sure people are dead. And I mean, and I think about it, it makes absolutely no sense in so many ways, but it is probably, I don't know what percentage of people I brought into hospice had that initial thing, had that initial fear that they're going to die when they get in hospice. They're going to do something to them, or, that's just what everybody expects them to do. And so it's the nice thing about the hospice program having so many people involved is that we can deal with so many of these questions over time. We can deal with their fears, we can deal with their expectations, we can deal with their ignorance about medication. And it's this huge process of getting people to feel comfortable about something that actually people were pretty comfortable about 100 years ago. Right
before we medicalized it all, right?
I remember seeing the movie. I'm not remembering names these days. Anyway, this movie that had it was in a field, and the guy was a sheriff, and Sally Fields was his wife, and he gets killed, and they bring him in and they lay him out on the kitchen table. And that was done in the 30s. And when I used to give talks to nurses, I always used to say, that was what you did when somebody died in the 30s, and that wasn't that long ago. They got laid out on the, living room table, dining room table, kitchen table. The family gets together.
The parlor.
They bathe the person, they sit around the person, and just all of this. And I think so much about people who get sent to the hospital, their families don't see them die. And and how egregious that is. And I was brought to get somebody in hospice who was dying in the hospital. And I go there and this man is in terminally ill and horrible pain. Has tubes all over him, has an IV. And so I get orders to give him morphine at certain times, so that he could be comfortable, and, to take some of the tubes out because he didn't need them, and do all of this. And I came back the same morning or the next morning, they had done nothing at all. They had not given any meds. They had not done anything. So there's this poor new nurse there. I said, you go get morphine now. We're going to do this. We're going to do this. We're going to take out the tubes. And so we're cleaning him up, and he's getting calm, and he's really relaxed, and he's beginning to die. And I said, do you have a wife? And he said, yes. And I said, what's her name? And he said, Gracia Diaz. I said, that's thanks to God. And he said, yes, my wife, thanks to God. And he died at that moment. It was so sweet. And
oh, that's so sweet.
And the family came in about 5 minutes later, and he was so peaceful, and he was so clean. And he looked relaxed, and the nurses, or the little RN, and I had made him look good. And the family came in, and they're like, I said, he just died a few minutes ago. I'm so sorry. And I looked at her and I said, his last words were your name. And she just was like, and made the death okay for her. And I thought, if they had walked in 10 minutes earlier, they would have seen a horror picture.
Right.
And instead, they got a memory of something good that he had been cared about, that he had been able to say her name. It was great. And that's another thing I like about the story about hospice, is we learn to tell their stories.
That's right.
To talk about the stories of the person, and we begin the next step while we're there. And that doesn't happen in a hospital.
And you gave
No.
the gift.
Yeah.
Yeah.
I went out, and I was serious. I went out to the nursing, and I talked to one of the nurses, and she said, we don't take care of people who are dying. And I said, well, you were taking care of a person who was dying. And they said, no, we don't take care of dying people. And I said, let me speak to the charge nurse. And she comes, and I said, your nurses are saying they don't take care of dying people. And she said, if a person is dying, they're supposed to go to the extended care. I said, yeah, but this person was dying and was here, and you didn't take care of him. And she said, you need to understand something. This is a hospital. We don't take care of dying people, period. I said, I will get my company to come and do education. We will come and train your nurses. We will talk to them. We do not do dying patients.
Right.
Yes. Yes.
What
Yeah.
need is there for a hospital for living patients?
Yeah.
I mean, if you don't take care of, everybody's dying. It's a matter of time.
Sorry, I got thrown off.
I'm flabbergasted.
I disappeared. My apologies. I don't know what happened.
You're with us. I see you.
I'm back.
Yes.
Thank you.
Yeah.
I'm not sure what I missed.
There was
that way.
it just is flabbergasting to
Oh, the wife. Yeah.
people who go into the hospital, in my estimation, are people who are sick and could possibly die. They're sicker than the one walking around on the street with the antibiotics or something. So if they're not taking care of dying patients, they're dying people, what are they doing?
Right. Yeah.
I mean, as an orthopedist, you put the leg together so that they can get up and walk on it.
Right.
The arm together so you can use it.
Another thing about, go ahead. I'm sorry.
That's all right.
Another thing about hospice is that there are actually peer-reviewed, published studies in peer-reviewed journals now that hospice patients live longer. For example, I think it was in JAMA, lung cancer patients actually live longer on hospice than they do with chemo.
Mhm.
I would believe that, right?
Yeah.
The history of living with chemo, I don't, but I see people who are trying. It's next to impossible. You're always sick.
Yeah.
Who wants to live always sick? So you give up.
Yeah.
You're comfortable and you've got enough pain medication to be comfortable. You're probably going to live longer. I think it's the comfort of life.
So you might live longer. You don't have to give up your doctor. You don't have to give up your insurance. You don't have to stop all of your medications. Hospice is about treating the illness that you have well, not about stopping all your medications and just allowing you to die. If you have, for example, heart failure and you're on hospice, the requirements say that you have to be optimally treated for your heart failure or refuse to be treated before they can admit you to hospice. So those are, again, some more of the misconceptions that people have.
Can anybody be admitted to hospice against their will?
No.
No.
Nobody is.
If someone doesn't have capacity to make decisions and they don't have a decision maker designated, and they're in a state like California where there's no legal designation, no hierarchy of designation, then the person who the doctors feel has their best interest at heart would be making the decision. And it might be that they could be admitted to hospice if they're terminally ill, but that wouldn't be against their will. It would just be someone acting with substituted judgment for them, right?
We're having a conversation. Guy from work. I can't think. Okay, I'm not following you. Don't come to us.
Yeah, I have to think of the name.
What's the story?
That he was the only one that gave you a question for this.
Oh, right.
Oh, that question, yeah.
Oh, right. He wanted to know, he's in his 80s, maybe older, and he's single, he's widowed, and he wanted to know how he could get palliative care if he needed it, living alone. So basically how he could.
So
Whoa,
we should talk about what palliative care is, maybe.
that's a good idea.
Palliative care from
So palliative care, hospice, if you think of a big oval, this is palliative care. And in the middle, there's a smaller oval that's hospice. So all hospice is palliative care, but not all palliative care is hospice. And the word palliative means to ease or relieve. So palliative care is active total care for patients with severe, chronic, progressive, or terminal illnesses who need support with symptom management, whose families also need support with helping them deal with their illness, the changes over time with their illness. And right now there are not universal types of palliative care programs. Some healthcare organizations like mine have inpatient consultation teams. They have clinics for palliative care. They have home-based palliative care. And some other organizations may just have one or two of those types. But I sent a link to you from the National Hospice and Palliative Care Organization, and I think it reads Caring Info, and it's specifically for patients and families to look up how to find palliative care where you live. So it will have
Right. Yeah, he's alone. He has friends, but he's definitely thinking about himself.
Yeah, the good thing about having a palliative care program, if he were to qualify for that, is that they will help you make arrangements for the caregiving that you would eventually need, because everyone near the end of life will need some hands-on caregiving eventually. And if you don't have family or don't have friends that could provide the care, palliative care programs and then hospice programs will help you find that.
Care for his partner who died the day before he was going to go on chemo. His partner died.
Sorry. His partner died.
Partner the day before his partner was going to go into chemo.
Oh my gosh. Wow, that's hard.
They were together probably 50 plus years. So a big loss.
But the point is, that is a single,
he sees himself
senior
alone.
individual get in contact with dying with ease is what I'm going to use the word, because how do you do it? And is hospice a way?
Sounds like it.
Yeah. Yep. For people who physicians can say, if this takes its normal, if the illness takes its normal course, they probably would die within 6 months, they would qualify for hospice. And it's not easy to tell that, but
That's a
you
guess.
don't have, you don't get dropped off of hospice after 6 months if you don't die either. As long as the physicians continue to say, if this keeps along this course, they probably would die within 6 months. We've had patients on hospice for years because prognostication is an art. It's not exact, and there's not always clear evidence for prognosis.
I thought, this is my thinking. I had a friend who was dying. She knew it, and she just had a dental appointment. And I thought, why is she doing this? I said, what are you going to the dentist for? Oh, the DNC. She was a gynecologist. The DNC of my teeth. And I was amazed that she was so close to death to have her teeth done, but she did. But,
that would be one thing I would not want to do if I was close to death, is go to the dentist. Everybody's different.
You know, Jen, I am aware that when
I think of death, easy death, I think of going to the house and saying, I don't feel too good. I think I'm going to lay down, pop my feet up on the sofa and just lay back and just go.
that's how everybody wants to do.
That would be nice.
I mean, my grandmother did that.
I'm saying
Lindsay, what?
people would like to go that way.
Right.
I don't want
But,
any.
but only
They're
only
pumping-
about a quarter of people get to die that way.
Yeah.
Only about a quarter of people get to die that way. It's like most of us die needing care from others for as long as 2 years on average, and 50% of us won't be able to make our own decisions when we die. So that's why it's so important to talk about this stuff. But Lindsay, you were going to ask me something, I think.
Well, I was going to say, kind of going into the palliative realm.
Can you move,
Mhm.
Liz, can you move closer?
Yeah.
I think I can hear you better then.
Is this better? Can you
A
hear
little
me?
better. Yeah. Move to your left a little bit. I'm trying to find your speaker.
My speaker is someplace, I think, in the middle. Like, maybe I'll pull this.
A little bit more to your right.
That's perfect.
I don't know what I'm.
There you are.
That's good.
That's
Okay.
much better.
Oh, I did that. No, but I was thinking about kind of doing a little segue into palliative care, because I think it's beginning to become more available, although I still think it's not used nearly as much as it should be. But I think people think, when they think of symptom management, they just think of pain management. You know, and I think, you know, if maybe you could discourse some about the kind of symptom management that's done in palliative care. Or is it only pain?
Sure. So is it okay if I use an example? This is not a real patient, but just
No.
let's say a woman was diagnosed with ovarian cancer, and a woman diagnosed with ovarian cancer, her first and best option is to have a major surgery. And someone who had that would be eligible immediately for palliative care. And so during the early part of that recovery, pain management would be a big part of that. But what happens really often with ovarian cancer patients is down the line, they get constipation or diarrhea or bowel obstruction or nausea and vomiting associated with bowel obstruction, or they may develop metastases or spread of the cancer to other areas, and they may get shortness of breath. Almost everybody who has cancer gets fatigue. Sometimes they get confusion, particularly then if the cancer were to spread to the brain, they'd get confusion. And all of those symptoms are things that palliative care can help manage. So it's definitely partly pain, but it's a lot more than pain. And even more than that, with a patient like that, part of our job also is to support her and say, okay, when this happens again, do you think would you want to go back into the hospital? Would you want to undergo more treatment, or would you want to focus on more on a comfort path? because you'll come to many forks in the road if you have a disease like that. And at each fork in the road, it's really helpful to have a team of doctor, nurses, social workers, chaplains, and others to help walk you through that. And even walk you up to the point where perhaps no treatments are going to be helpful except for comfort focused treatment, and then getting hospice involved. And at that point, it's not a big surprise because the conversation has been ongoing. So prior to palliative care, when there was a severe illness like that, you go along, treat, go to the oncologist, get everything done. And then all of a sudden, when things stopped working, your only option was hospice. And during that time, while you're undergoing different kinds of treatment, this woman would have, again, pain, nausea, vomiting, diarrhea, shortness of breath, constipation, all these things. And frankly, oncologists, it's not part of it maybe is a little bit a part of their job, but it's helpful to have people who specialize in symptom management to come on board and help with those symptoms.
So the oncologist doesn't do that as a general.
Well, the oncologists do that, but their focus is treating the cancer, not treating the symptoms from the treatment or the symptoms from the cancer. That's what palliative care, that's the gap that palliative care really was developed to fill.
Got it. This would be a good time for you to tell a story about that dentist that came in.
Yeah, I was doing pain management at the time. And this relatively healthy looking middle-aged guy comes in, has a lot of shoulder pain, tells me about it. And I said, well, take off your shirt and I'll take a look. And he says, nobody's ever asked me to take my shirt off before. I said, well, I can't see your shoulder without your shirt off. And he did take it off, but he was amazed that I asked him to take it off so I could see it. And he had this big mass on the back of the shoulder. And I sent him for a couple of studies rapidly. And he had cancer of the scapula, which is something I had never seen.
Oh my gosh, painful.
And so I got on the phone and got him into the oncologist that day. I mean, from the time he hit our door, he had standard x-rays, an MRI of the shoulder, and off to the oncologist the same day. But you could see why it hurt. I mean, it was this big red mass that, if you took a breath, it stretched or moved, and it would have to hurt. I mean, incredible. So I gave him some pain medication. He went to the oncologist, got some more, came back to my office, wanted something else, and then 2 days later took his medication all at once, which I frankly didn't blame him because he wasn't going to get better.
His wife was with him too.
Yeah, his wife was with him the whole time, and she came in and she did tell me that was a purposeful act on their part. I said, well, I'm not repeating that because that would put her in jeopardy.
Yeah. Yeah.
Just amazing,
Wow.
amazing that someone had let that go all that time without looking at the person and looking at what was happening. I mean, I knew the medication I gave him wouldn't kill him, but I didn't know if the oncologist had something else they could do, like irradiate the hell out of it or something. I didn't know. But it was certainly incredibly painful. And to give someone like that pain medication, so they take it all at once. That's their choice. It's not something that I was encouraging, but it's certainly his choice. I think it was patients who ever did that.
That was probably long before he would have had that as a legal option, right?
It was before the legal option.
He was he knew what he was doing.
Yeah, as a dentist, he knew what he was doing.
Yeah.
He just wasn't letting anybody around him except his wife know, and she knew what he was doing. She actually thanked me. But I look at that fella, and somebody missed the boat on him 9 months to a year before I ever saw it. Mm-hmm. And that's where I think it comes in to help these people with pain management, with care, to get through those last few months comfortable. he was certainly uncomfortable. He was in a
Well, he could have been diagnosed a lot earlier, and then he could have, if there were a palliative care program available for him, they could have been with him to help him talk through the choices that the oncologist gave him and help him with any symptoms, and then talk through the choices for the end of life choices as well. And he didn't have any of that. So
with somebody like that, I think what else is the option? If you could take pain medication, kick your feet up on the sofa and slide out, why not? Makes sense to do that compared to struggle along every breath you take, screaming through your shoulder and arm.
yeah, that's terrible.
I just, for me, I don't know if it was who I am and the way I look at things, but I would get that kind of patient commonly before they got to his point, so we could help them with their medications. But that the rule of today that, oh my God, my kid broke his ankle and was addicted to Vicodin 2 days later and killed himself, that isn't exactly the scenario I ever saw. You know, I saw people who were older, in a lot of pain, sometimes chronic pain, without putting a death patch on it. You know, like that guy, he had a death patch on him before I saw it. You know, he was ready to go. And
You're not talking about medication.
no, I'm
A label.
A label. He was
Oh,
he was ready to go by the time I saw it. But a lot of times I'd see people with, say, a bad back. It's not going to kill them. Makes it hard to get up and go to the bathroom. Makes it, you can't really walk very well outside, so you don't take your dog for a walk. I mean, they live a very closed-in life, and they don't appreciate it. And after they've been on medication for 3 weeks, they're accustomed to it to the point that many of them could even drive and do a good
right.
job.
Because not everybody has a problem that surgery is going to fix, or not everyone's going to choose to have surgery. But people are now, because of the opioid crisis, everybody's so afraid of being prescribed those medications. But they can be prescribed safely.
Yeah,
They can be titrated and down, and you can get off of them if your pain is able to be fixed another way.
well,
So I think there's more. Go ahead.
I had a lot of patients who were post-op total knees, and I would typically get them at about the 3rd or 4th day post-op. And it's an incredibly painful surgery. I don't know exactly why, but it's very painful. And I'd walk in and they'd be grabbing a hold of the edge of the bed, you know, like that, and get them going on medication and come back later in the day and they'd at least be able to settle back into bed. And in 3 months, those people would be pain-free enough to go without medication. And typically, I had no one in my practice after 3 months of a total knee.
People were afraid of becoming addicted.
Yeah, terrified of addiction.
Yeah.
Which I don't look, there's addiction and then there's need. When you have need, that's different.
Right, because you can, your body, if you need to take pain medications because you have pain that can't be treated a different way, your body can become physically dependent on the medications, but that's not addiction.
Right.
Because addiction is a behavior. It's taking the medication to get high, not to just treat symptoms.
I've not seen many pain medication, people with pain, when given pain medication, get high. They don't get high, they just get relaxed.
That's true. If you have pain, you rarely feel high when you take the pain medication. You just don't feel pain.
Right. It is not a high. I've never had
No.
post-op totally later in the day say, boy, am I high? No, they say, oh man, am I relaxed? You know, the pain's eased. They never say it's totally gone. They say it's eased. But it's amazing how frightened everyone is that they'll be addicted by using even mild pain medications. And I'm not talking about Tylenol. That doesn't do much for pain.
No.
You know, that's, I don't know who thinks Tylenol is a pain medication.
It's well marketed. It is. Oh, I'm on extra strength Tylenol.
But I had 92 through 96-year-olds on substantial morphine, but it helped them get up in the morning, get out of bed, fix their breakfast, go to church, whatever they were going to do that day. So to me, that's not addiction. Without that, they were in bed and crapped out.
Exactly. I mean, I've had the same thing. I've met patients who were referred to hospice who were writhing in bed in pain. And it was either because they were afraid to take medications or the doctors were afraid of giving them the medications. And once we got them on the right medications, and sometimes that could be IV morphine even, or IV hydromorphone, which is quite a lot stronger than morphine, or even IV methadone, which is a very strong medication. They can be alert, awake, oriented, and one of them got up out of bed and danced at a wedding.
Yeah.
So it's
Different.
really important that we treat pain in these patients, that they don't suffer needlessly.
The presentation was, as you know, but I'll repeat it for people who haven't heard it. When we interviewed you, Jennifer, for the collection, at the end of the interview, you and Marge started talking about pain management. And I'm educated as an RN, but you taught me things, you both did, that I hadn't thought about. And I appreciated that. And I said, let's share this, because it brought me a level of education and knowledge that I'm grateful for. So I think that's what we're doing here, is bringing that to other people. And, I'm delighted to meet you.
Thank you. I got into the kind of work that I do because my mother died of cancer and died in a hospital and virtually never had her pain managed. So I realized during that experience how critical this is and how terrible it is for someone to die in pain. Someone you love to die in pain.
Totally.
So if I've helped one patient not die in pain, then I've made a difference.
That's a great statement. I mean, and Lizzie's father was exemplary. He was a person that could give injections, but most people can't do that kind of intervention. And they need support, and they deserve it. You know, we get support when we're living. We need support when we're dying. I would also like to mention that in pain management and anything that medical, I'll just stick with medical, you need an advocate, somebody that's there for you, like that patient you talked about with his shoulder. His wife was there and supporting, because it's lonely and you don't hear well when you're anxious.
Yeah.
This is talking about the end of your life is kind of a calming situation. And going in for pain treatment is also, you live with it before you see the doctor. You don't get pain and go the next day to the doctor, usually. So an advocate is really important. Sue, who was going to be part of this, but isn't, she and her partner were in Palm Springs. They had a lot of pollution in the air at this time. They were there for the weekend, and her partner, Lynn, started coughing. Well, it ended up that how would you explain it?
She herniated two discs,
right,
from the force of the coffee. And that's not uncommon.
So anyway, so then
Oh.
Sue ran an operating room in Seattle, and Lynn's first intervention, because she had so much pain, was recommended by this doctor. Put a lot of metal in her back, do a fusion, and Sue, being knowledgeable, said, well, let's go further, find somebody else, because she didn't like the idea of surgery. She knew that this kind of surgery had a lot of future problems, and she was correct. But so they found somebody else who made a good diagnosis. Was he a neurosurgeon? Or? Okay.
And he simply went in and took out the offending disc material.
And she's good. She's back to herself. She's gardening. She's doing her life. And so the advocate part of the,
Sometimes the advocate can hear the nuance
right,
of what you say. And the person is so blown away, they can't.
right.
I never minded my patients bringing someone in with them. Because I know that then afterwards there would be more discussion.
Yeah.
When she said that.
Yeah.
If you're hurting or you're scared, you're not going to hear everything.
No.
So it's so good to have someone with you.
So I think having an advocate with you, you know, if I said something to them, this is the care I would recommend, and they said, I don't want to do that, I'd say, well, what do you have in mind? You know, and if it was something that was not within my scope, I would say, one, I don't do that, but two, I don't know anyone who does. So you need to find somebody else. And, you know, particularly when they go into the Eastern medications,
Mhm.
I don't know. I was always hard pressed to keep up with the Western medications and to know really what they did instead of what they said they did. And I have no knowledge of acupuncture or things like that. So if that's what they want, they need to find a valid acupuncturist. You know?
And they exist.
And they exist. I just don't know them. And
They do, and more of our patients are using integrative health now. More of them are using acupuncture or traditional Chinese medicine or cannabis or all that. And so it's important that we at least create an atmosphere where they can tell us about it, even if we don't know a lot about it.
Appreciated you because you didn't say, "Oh, are you serious?" I mean,
Yeah.
well,
Yeah.
I don't know. Just because I don't know it doesn't mean it doesn't work.
right.
You know,
Right.
I'll never forget sitting in LA County and they have this operating room that I think was designed in Hollywood, because you sit there and down here and you're up there in these towers and these beautiful windows and everything.
It was the set.
I remember that operating room.
Fab sets, right?
Yep.
Right. They were demonstrating something under acupuncture, and the surgeon was doing brain surgery just under acupuncture. I mean, he had the brain exposed and the skull cut in half. And I'm sitting there going, Jesus Christ, we don't know anything about this. Nothing. Zero. We put people to sleep and knock their lungs out to get the same anesthesia. I was totally impressed.
Yeah.
I don't think,
And
not only that, but I was sitting in the biggest showroom in the world. But it was impressive that was working. I'll never forget. Just,
Yeah, I saw that.
yeah, I mean,
But
there's
you
a
know
lot
what?
that probably works. We just don't know because we
Okay,
can't study it.
But I saw that too. I'm sorry I didn't hear you. Say that again.
I just said there's probably a lot that works that we don't know about because there's no incentive to study it.
Yeah.
You know, there's no incentive to do randomized controlled trials on Chinese medicine, or it's difficult to do studies on something like acupuncture. So we just don't know.
we had just no idea. But that opened my eyes, I will say.
Mine too. I was working in the operating room at that time also, but nobody said, "Well, let's sign up and do another one of those acupuncture surgeries."
Yeah, let's do a hip under that. But
Right.
that didn't
It
happen.
was just, but they did flip the flap and open it to the brain. We all saw it.
Wow.
Yeah.
Way. And the patient was not uncomfortable.
But you know what I saw with the patient? This is something you and Jennifer, and I know Lindsay does. They connected. That person was right there under the drape talking to that patient the entire time.
Yeah.
And that is so important. And that patient went through it.
Blew me away.
Yeah.
You know,
What did you say, Lizzie? What?
No, I was going to say, when I had cataract surgery, this is what they do at Kaiser now. Everybody gets popped an Ativan, like 1 milligram, half milligram Ativan. And then during the surgery, because you're wide awake, they hold your hand. And I just loved it. There was a nurse the entire time of the surgery holding my hand.
Huh.
Yeah, it was and it was remarkably calming and soothing. And it was a good thing to do rather than give like pain medications or things like that.
That's awesome.
It's so fun. Yeah.
Yeah. And you know that when we're doing hospice, we do that all the time.
Yeah.
That's right.
Yeah.
You're not afraid to touch the patient.
Mm-hmm.
You have to. I mean, hospice and palliative medicine, particularly hospice, are high touch, low tech.
Yeah.
It's getting a little more high tech, but it's mostly high touch with less tech. So you absolutely touch the patient, and that's therapy.
Mm-hmm.
I always remember that dentist who was amazed that I asked him to take off his shirt.
Yeah.
Totally blew me away.
Yeah, that no one had ever done that. No one had ever examined him before. That's just so terrible.
But there's a lot of that today. You know, you go get the blood, you go get a blood test, you go get this test, you go get that test, but nobody asks you to take your shirt off. Right.
Yeah.
You got a lot of tests.
Amazing.
So I think we're good.
Good. That went well.
This has been wonderful.
Yeah.
Yeah.
Thank you.
Thank you.
Yeah.